the development of acute myeloid leukemia in a patient with an underlying myeloproliferative disorder is one of the most challenging clinical scenarios faced by haematologists, because unfortunately this situation, despite huge increases in the knowledge of the mechanisms of why it happens, we haven't really seen significant improvements in patient outcomes over the last 3 or 4 decades. Unfortunately, a large proportion of patients who have myeloproliferative neoplasms that change to AML are relatively elderly, so the median age that it takes place tends to be patients in their late 60s and 70s, often have significant degrees of frailty due to sometimes a number of years with the underlying myeloproliferative neoplasm. And unfortunately, we know that the genetic changes associated with those changes are unfortunately genetic changes that often make the disease very resistant to conventional AML treatments, or if it does respond to AML treatments, it's often a very temporary response. So generally the approach over a number of years has been that for patients who are young enough and physically fit enough to undergo this type of treatment, we would try to get patients into remission with intensive chemotherapy type treatment and then get them through to an allogeneic stem cell transplant. And that's really the one type of treatment in post-MPN AML that has been associated with potential long-term responses and long-term cure. However, there are a number of new drugs which are becoming available for the treatment of AML, and they're just possibly going to change the treatment algorithms and how we treat these patients in coming years. So one of the drugs we now have available in recent years is a liposomal chemotherapy formulation called CPX-351 or Vyxeos, which has recently been licensed for patients with secondary AMLs and patients with myelodysplastic syndromes that change to AML. Unfortunately, myeloproliferative patients weren't one of the groups of patients that were included in the main trials of Vyxeos, but there are a number of indications such as the cytogenetic abnormalities seen in MDS-related AML that do cross over into post-MPN AML. So many patients with post-MPN AML who are suitably fit for an intensive chemotherapy approach may be able to receive Vyxeos, and that carries the potential of being able to potentially deliver patients to transplant in a slightly fitter state where they're able to undergo the rigours of transplant. The other drugs which are potentially going to be available in AML in coming years are venetoclax, IDH inhibitors, and also adding in JAK inhibitors to hypomethylating agent treatment, which is the standard treatment for patients who are not physically robust enough for intensive chemotherapy and allogeneic stem cell transplant. Many of the clinical trials that have been done in those for AML with those drugs have not featured many patients with myeloproliferative neoplasm associated AML, but it is possible to start extrapolating the findings from those studies. And I think in the coming years we will see a lot more of patients in this difficult group receiving those drug combinations, and we can potentially look forward to better responses. There are also a number of other genetic targets, such as MDM2 with MDM2 inhibitors and also BET inhibitors that are showing potential promise, and they're going to be looked at in forthcoming trials in post-MPN AML.